আমাদের এখনকার লেকচারটির বিষয়বস্তু হলো ইউরিনারি ট্র্যাক্ট ইনফেকশন। এখানে এটিওলজি, ক্লিনিক্যাল ফিচার, ল্যাবরেটরি ডায়াগনোসিস এবং ট্রিটমেন্ট সবগুলো বিষয়ে সংক্ষেপে আলোচনা করা হবে। ইউরিনারি ট্র্যাক্ট ইনফেকশন বলতে আমরা বুঝি microbial invasion extending from renal cortex to urethral meatus. This is the second most common infection in the community after respiratory tract infection, and this is the most common hospital-acquired infection, which consists of about 35% of all healthcare associated infection. About 10% of humans develop UTI in some parts of their life, and more in case of female. They can be classified on two bases, based on site and based on source. Based on site, upper and lower UTI. Upper UTI means infection of the kidney and ureter. Lower UTI means infection of urethra to bladder. And based on source, it can be community acquired and it can be hospital acquired. This is the source of the bacteria. The predisposing factors, females are affected more. 50% of women suffer at least one episode in their lifetime, and in 50% cases, they have reinfection within 1 year. Age, it increases with age. It is most common during the adult life. 10 to 20% of the female suffers, and during 5 to 17 years, 1 to 3% in case of female, and during first year, around 2% in both sexes. Pregnancy is another predisposing factor, and structural and functional abnormality like stone, like prostatic hyperplasia, these are also, and functional like injury to the spinal cord or upper center, neurogenic bladder, those are also predisposing factors. This is the etiology of, this is mostly due to bacteria, but only one fungus, few parasites and virus can also be infrequently infected. And of the bacteria, commonest is Escherichia coli, around 70%, Klebsiella pneumoniae, Enterobacter, Proteus, Serratia, and other Enterobacteriaceae. Pseudomonas aeruginosa, Acinetobacter, they are also important. Neisseria gonorrhoeae and chlamydia, they are acute urethral syndrome. Among the gram-positive bacteria, Enterococcus, Staphylococcus saprophyticus, Staph aureus, and nowadays Staph epidermidis is also considered. Streptococcus group B and Mycobacterium tuberculosis are rarely leptospira. Among the fungus, Candida albicans. Among the parasites, in the Middle Eastern and South and Africa, Schistosoma hematobium is an important cause, and in all over the world, Trichomonas vaginalis. Viruses, BK virus, which is one of the polyoma virus, adenovirus type 11 and 21, and herpes simplex virus can also cause urinary tract infection. Pathogenesis, it is by two routes, ascending and descending. Ascending route is the most common. The endogenous bacteria like Escherichia coli, Enterococci, other gram-negative bacteria, which are our normal flora, they can ascend through the urethra to bladder, and this ascending route is facilitated by sexual intercourse and instrumentation. Descending route, invasion of kidney from hematogenous seeding, usually Staph aureus, Mycobacterium tuberculosis, Salmonella, and Leptospira. Leptospira, they can cause this type of infection. Clinical manifestations varies with the site. Lower UTI can be asymptomatic bacteria, cystitis, urethritis, and acute urethral syndrome. Upper UTI can be manifested as pyelonephritis, ureteritis, renal abscess, and renal tuberculosis. Of which asymptomatic bacteria is very common when significant count of bacteria, which is 10 to the power 5 per ml of urine, in persons without symptoms, then it is known as asymptomatic bacteria. It is usually insignificant. It does not need any treatment except pregnant women, patients undergoing any urologic procedure, including prosthetic surgery. We will discuss the treatment in details in later slides. Cystitis, it is one of the lower UTI. Symptoms include dysuria, painful micturition, frequency, urgency, and suprapubic tenderness. Signs, among the signs, urine becomes cloudy with bad smell, sometimes hematuria accompanies. There is usually no associated manifestation like no systemic manifestation like fever. Acute urethral syndrome, it is usually seen in a young sexually active women, characterized by classical symptoms of lower UTI. Here bacterial count is low, less than 10 to the power 5 per ml. Pyuria is present and with or without growth, because this is caused by Neisseria gonorrhoeae, chlamydia, or herpes simplex virus, which are usually non-culturable in routine media. Pyelonephritis, it's the inflammation of renal parenchyma, renal pelvis, and calyces. This is associated with systemic manifestations like fever, flank pain, and vomiting, and lower UTI symptoms like frequency, urgency, dysuria may also be present. Laboratory diagnosis. The gold standard is semi-quantitative culture with a significant colony count per ml of urine is the gold standard. Screening tests like wet microscopy, gram staining, leukocyte esterase tests are also helpful. Now the question is, in other laboratory, other diseases, we don't need quantification of the growth, but here, why we need quantification? According to Cass in 1955, the answer is to differentiate contamination or colonization from infection, because same bacteria which cause UTI, they can contaminate the urine during collection, or they can colonize the urethra. And in case of contamination or colonization, the count will be always low. It will be always less than 10 to the power 5 per ml of urine. Now the question is, what is significant bacteriuria? There are many situations. A count of 10 to the power 5 colony per ml of urine of a single bacteria or two bacteria are always significant. If there are more than two types of colony, that indicates contamination, and it is to be repeated with a fresh, clean catch sample. The count between 10 to the power 4 to 10 to the power 5 is a doubtful significance, should be correlated with clinical condition. If the count is lower than 10 to the power 3 per ml, usually of no significance except in following condition. If the patient is on antibiotic or diuretic, if the infection with gram-positive bacteria like Staphylococcus, Saprophyticus, aureus, enterococci, etc. Pyelonephritis, and in acute urethral syndrome, there is also a lower count. And if the sample is taken by suprapubic aspiration, there is then no need for colony count. And the catheterized symptomatic patients, colony count around 10 to the power 3 per ml of urine is significant. Laboratory diagnosis steps, sample collection is very important. the clean catch mid-stream urine or suprapubic aspiration or from catheter tube, not from bag, is very important. Without the careful collection of the urine sample, there is a very chance of contamination. So the patient should be instructed clearly to wash the periurethral region and then to collect the mid-stream portion. It should be transported as early as possible. If there is delay for more than 2 hours, to be stored in the refrigerator, or boric acid should be added. Otherwise, the colony count will be falsely increased. Among the screening tests, microscopic examination, weight preparation, if the count is more than 8 parts cell per cubic millimeter, then it is significant. Leukocyte esterase test, it is done by strip test. This is also helpful. Gram staining usually in lower UTI not helpful, but in upper UTI, pyelonephroid is an invasive UTI helpful, and 1 bacteria per oil emission field is significant. Culture, quantitative culture, the media used, plate is the ideal media, or Mekong agar and blood agar combinedly can be used. Quantitative culture by standardized loop or micropipettes, calculation, easy calculation. If 10 microliter of urine is inoculated in the media, 1 plate, then if there are 100 colonies, then the count will be 10 to the power 5 per ml of urine. If more than 100, more than 10 to the. If it is less than 100, that is 10 to 99, then it is 10 to the power 4. It is, if it is 10 less than 10, 10 to the power 3. Identification by biochemical test or automated system, and sensitivity by distribution or MIC based automated system. How upper UTI can be differentiated from lower UTI? From clinical feature, microscopy of urine, and antibody detection. Treatment of UTI depends on type and causative agent. In case of bacterial UTI, sensitivity targeted therapy depends on sensitivity test, and before sensitivity test, it is based on the resistance pattern of that area. Let us discuss the individually the symptoms, the clinical classification. Asymptomatic bacteria, as we have said before, treatment is required only in pregnant women or who and patients undergoing invasive or urologic procedures. In pregnant women, amoxicillin, nitrofurantoin, or oral cephalosporin can be used for 3 to 7 days. And in the second trimester, cotrimoxazole can also be used. Nitrofurantoin to be avoided in third trimester due to risk of hemolytic anemia in the newborn. And confirmation of the clearance of asymptomatic bacteria is recommended in pregnant women. Next is acute uncomplicated UTI in adult female. Primary regimen, this is empiric therapy, cotrimoxazole double strength 1 tablet, BID for 3 days only, nitrofurantoin for 5 days. Alternate regimen, fosfomycin, single dose, ciprofloxacin, only 3 days, but just you notice, if any beta-lactam is used, that should be 5 to 7 days. Acute uncomplicated UTI in male. Primary regimen is Cotrim for 7 days, nitrofurantoin 7 days, or ciprofloxacin 7 days, levofloxacin also 7 days. Alternate regimen, amoxicillin 7 days, cephalexin 7 days, and fosfomycin 3 gram every alternate day, 1 to 3 doses. If sexually active males are rule out the gonococcal cystitis and chlamydia infection by PCR. If recurrent infection, evaluate for prostatitis. Cystitis plus symptoms of bladder outlet obstruction usually indicates concomitant acute bacterial prostatitis, and look for any obstruction via imaging as soon as possible. Further comments regarding this acute uncomplicated UTI. Some drugs do not penetrate the prostate, like nitrofurantoin, beta-lactam, and phosphomycin. So they should be avoided in case of male. If prostatic hyperplasia is prostatitis is in consideration. Among other important consideration for recurrent UTI, it is to be evaluated for benign hyperplasia of prostate or other causes of obstruction. If recurrent UTI with same pathogen, chronic prostatitis should be considered and treatment should be according to that line. Complicated UTI or catheter-associated UTI, empiric regimen should be ciprofloxacin, oral or IV, levofloxacin per oral or IV daily, once daily, alternate regimen, cotrimoxazole or nitrofurantoin. If high risk of multi-drug resistant organism or systemic illness, then ertapenem, piperacillin, tazobactam, cefepime, ceftazidime, avibactam can be considered. Duration of therapy is usually 7 to 14 days. If the sign symptoms of upper UTI persist, then 14 days. For COTI, 7 days if prompt resolution of sign symptoms. Pyelonephritis. The empiric regimen for pyelonephritis, if it is ciprofloxacin, then 5 to 7 days. Levofloxacin also 5 to 7 days, but any beta-lactam 10 days. If high risk of MDRO or critical illness or prior Pseudomonas infection, then meropenem should be considered. Meropenem, piperacillin, tazobactam, cefepime, or ceftazidime, avibactam. And duration, again, with uncomplicated pyelonephritis, if fluoroquinolones are used, 5 to 7 days. If it is complicated, then 14 days. But with beta-lactam, it is always more than 2 weeks, about 2 weeks or more than 2 weeks. Thank you very much.